dumps into the stomach in the middle 1/3 of the body of the stomach. It immediately absorbs acid out of your stomach, so pH goes up. Any elevation of pH, even if it's 2.01. Peristalsis begins, because now you've distended smooth muscle. Peristaltic wave will push that 2.01 over to the antrum where the G cells are located. The G cells have put out a whole bunch of gas. The gas goes back to the antrum, the body and fundus of the stomach, stimulates the parietal cells to produce HCl and intrinsic factor. HCl is to digest and melt down the proteins, but it also denatures salivary amylase, salivary lipase. And that's how to remind yourself there's no fat or sugar digestion going on in the stomach ever. The other role it plays is digest all the bacteria in all that food that you just ate. There's bacteria in every food that we eat. Okay? Once that pH comes back down under 2, wham, chief cells then release pepsinogen. Pepsinogen then gets denatured to pepsin, and pepsin then starts to digest the protein. Pepsin does not come out into your stomach until after age 1. When are we supposed to start table foods in children? Oh yeah, that's right, age 1. See, I told you it's always about basics. Okay, until age 1, your stomach is putting out another enzyme. Let me just write up here. It's called renin. Notice the difference. It's 2 N's rather than 1 N. So please be careful which one you pick by accident. Okay, so renin, that's how I put it, renin is present in the stomach until age 1. That's why we tell parents don't feed table foods until after age 1, because that can only digest milk proteins. So if you put other proteins in here, he can't digest it. So that's why we're always constantly asking mom, what are you feeding this baby? The strangest story I ever had was this one, little teenage girl. I said, what'd you feed your baby? And yeah, I'm feeding some Gerbers. I'm writing it down, Gerbers. Yeah, there's some Similac every now and then. Oh yeah, and he loves chicken wings. Oh yeah, and he loves it. Whoa, wait a minute. Did you say chicken wings? 2-month-old baby, she's telling me this. Oh yeah, Dr. Frank, he loves some chicken wings. You know what, the other day, hey, Dr. Frank, there's a chicken place right over there in that mall. You know, I bought some wings, and I was eating my wings, and my baby looked like he was kind of hungry, so I said, I wonder if he likes some wings. Teenagers don't know anything about babies. They get pregnant real fast, but they don't know it. Anyway, she said, I just gave him a little piece. Ooh, he just, she doesn't know that's just a reflex. All babies have a suck reflex. You put it in their mouth, they start sucking at it. And she thought that meant, oh, he loves chicken wings. And I was like, good Lord. Anyway, that's the kind of thing that'll cause that child a lifetime of eosinophilic problems. Esophagitis, gastritis, colitis, for the rest of their life, if she had just kept feeding that stuff. That's why as pediatricians, we're always asking, anything else you're feeding them? And then you find, no, don't feed them that. That's too early. He cannot digest it. That means it's just going to go through his GI tract, irritate the hell out of eosinophils, because he cannot digest it. He doesn't have the enzyme. It doesn't matter that he likes it. Okay? All right, so renin versus renin. Stomach cell lining, here's how we make everything. So again, notice, you got in the lumen, we want to get H and Cl up here, all right? So what do? Take up CO2 and water. Notice, every time we got to do something, remember CO2 and water got to come in again. Come on, hydrates got to help me again, and I make H2CO3. Breaks up the hydrogen and bicarb. Everybody understand what I've done so far? Well, Angie, I need to get the hydrogen into the stomach lining here. You follow me? So you're pumping against the gradient. That's why you need an ATPase for that to happen. So it's called a hydrogen potassium ATPase. It works just like the sodium. 3 hydrogens, 1 potassium. Anytime you break the first phosphate bond of ATP, how many calories are released? Ashni, you remember? Huh? Yeah, 7,300. And that's all the energy you need to go against this gradient. Because you remember, your stomach pH is 1 to 2, your plasma is 7.4. You're going against a huge gradient. Okay? So hydrogen is now in the stomach. But if you're doing 3 to 1, does everybody understand this cell is getting more negative? Right? Just like 3 to 2 is more negative. Everybody follow that? It's math, right? Anybody lost already? Okay. Some of you are not convinced. I don't see it. All right. Anyway, it's math. Check the math for yourself. All right. You're losing 3 and breaking back 1. You're losing. So it's getting negative. What's that going to do? Push chloride in there. Remember, chloride is the only one driven by electrical gradient more than anything else. So the chloride now follows hydrogen in here, Look at that, you got HCl to digest your food. So they'll ask you how HCl actually gets to the stomach. I want you guys to see that for yourself. Again, it's a matter of studying this picture so you understand it. However, when HCl goes in your stomach, what's your body do with the bicarb? Look at this, Ashley. The bicarb is pumped into this space underneath your stomach lining. They call this alkaline tide. That means there's a bunch of blood with tons of bicarb underneath your stomach when you eat. Why? In case any acid tries to burn through it and go in, you neutralize it quickly. Alkaline tide. Any questions at all? All right. Stomach protection then. Mucus from goblet cells. Because you're putting out so much acid in your stomach, you better have a ton of mucus in there. Mucus, glycosaminoglycans, is so thick that acid can't eat through it. That's what protects you from getting gastritis after every meal. Okay? Prostaglandin E also promotes mucus production. At least now you see how aspirin, NSAIDs, and steroids promote ulcers. Bicarb is your third protection. The alkaline tide I just spoke of is underneath the stomach lining, and it stays there until digestion is done. That means until the stomach is empty. And typically it takes about 40 minutes for food to hit the stomach and to go into the duodenum. But it takes about 3 to 4 hours to completely digest everything that you've eaten. All right, aspirin, we've talked about before. Aspirin has 4 main actions. Remember, antipyretic, antiplatelet, anti-inflammatory. What's the last one, Gloria? Analgesia, pain relief. Remember we talked about the 3 blood gases? I already went through it for you. I just put it here again just so you guys can look at it, review it. Remember, initial versus 90% versus late. Don't forget. The key is be able to talk it out and see how did you get each one of those blood gases. Don't just memorize them. Okay? All right. Gastric ulcers due to aspirin or NSAIDs, what do we tell patients? We either put the prostaglandin back in the form of misoprostol, or we give you a COX-2 inhibitor, which does not bother the COX-1s in your stomach. The only claim to fame of COX-2 inhibitors, folks, is that they have the lowest GI irritation rate. Everybody understand why? Does everybody understand that? You have mostly COX-1 in your stomach. Well, these are COX-2. They don't bother it. But it's never 100%. So that's why they say lowest incidence, not 0 incidence. Okay? Misoprostol, however, is a prostaglandin E analog. But it breaks down the same percentage as I gave you before. 80% vasodilation, 20% vasoconstriction. Which is why they say do a pregnancy test. If you're about to start a female on this, and she's of childbearing age, 15 to 45, you got to do a pregnancy test. But on a test, they'll just say, what's the next step in your management? You're supposed to know what to do next. You never start that drug in a female without doing the pregnancy test. Because if it expresses a vasoconstriction, you got a dead baby now. Okay? Misoprostol. Misoprostol is also used as a abortifacient for the same mechanism, obviously. COX-2 inhibitors, all anticoxib. Their claim to fame, again, lowest incidence of GI irritation. However, they're all made out of sulfur. Describe one side effect of sulfur. And now go. I'll give you guys 4 weeks to know all the side effects. I don't want to hear no excuses. Okay, you've had 4 weeks to look at it. I told you it's going to come up soon. Go. Just give me one. One side effect of sulfur. And the name of this reaction is called what? We'll come back. Gloria. Anaphylaxis is the worst that can happen. Yeah, but he can go with the name. All right, Sadiq. Oh my God, first row, we're already short on 2 people? So out of 3 on the side. Oh man. Okay, give him one. Stephen Johnson, give him one. 10. Toxic epidermolysis. All right, let's go. B, give me one. Acute tuberculosis. Justin, give me one. What? Non-specific rash. Come on, man, give me one. What? Treatment asthma. Sulfur drugs don't cause asthma. You got to give it a different name. You can't pick that. If you pick asthma, your answer's wrong. No, it doesn't do that either. It does in a different way. You got to name it the way I named it for you. If you just say that, that's not the answer. All right, Anders, what allergic reaction is that? That's what I'm asking you. Allergic reaction for sulfur. Name one. Don't just say allergic reaction. I don't know what that means. I'm asking you to name them for me. She gave me anaphylaxis, Stevens-Johnson, TEN. It causes eosinophil failure, but what's the name of the reaction? We'll come back. Summer. What is the name of this? Type what hypersensitivity? I don't know what you're talking about. What's the name of you try to tell me? She told me anaphylaxis, Stevens-Johnson, TN. They're all type 1s, but they all have names. Remember, I grouped it up for you, type 1, type 2, type 3. And now you guys are giving me a bunch of general titles. I want to hear general titles. I told you guys, you got to be specific. Because on the exam, they give you somebody who was put on sulfur drug and they come back complaining about blank. You got to know what side effect that is. Okay? You have to know it by name. Karis. I know what? She knows none. Peso.
I don't know anymore.
Oh my God, Lord, I'm a failure. I'm sorry. Hey, come on. You know how many drugs are covered with sulfur? You guys can't draw blanks on sulfur. This weekend, make sure you know it. I'm going to ask it again on Monday. I don't hear any excuses. And we look at me all strange because there are too many drugs with sulfur to go into that exam. You don't know the sulfur allergic reactions. That means you're going to miss a lot of questions because I see these questions all the time. Okay, if you know how to describe each one, they're easy questions. If you don't know what they are, you're going to miss a lot of questions because they're not going to give you a general title. That's not it. All right, Anders. Serum sickness. That's a type 3. Yeah, okay. Give you guys a reprieve Monday. All right, so COX-2 inhibitors. The bad thing with COX-2 inhibitors, remember they block all your prostacyclin. I told you guys about this. They create cardiovascular risk. Prostacyclin normally inhibits platelets. You block all of that, they can get clots anytime. But remember, I told you it's usually after 18 months of use. So it's long term, it's not acute. So that's why they now encourage do not use COX-2 inhibitors more than a year to 15 months. Stay away for 18 months because that's when we start to see strokes and MIs. The other one still on the market right now is celecoxib anyway. The other two are already taken out. All right. COX-2 inhibitors all contain sulfur, so sulfur allergic reaction. And in long term, no more than 18 months, you're going to run into coagulability. All right, these we already talked about, so I'm just going to review them quickly for you. Remember, stress ulcers have to do with the parasympathetic discharge coming first, sympathetic discharge coming second. And I gave you Cushing's ulcers when it's due to intracranial pressure. Curling's ulcers is when it's due to burned skin. And then stress ulcer is just a term we give when any stress causes. So in the ICU, all right, they say the ICU is the most stressful part of the hospital. What does that mean? They did a study, the most cortisol is put out when you're in ICU. Okay, that's what they're talking about. To me, it's usually sitting right there next to the cashier looking at my bill. If that don't cause you stress, I don't know what does, man. That bill, I don't know. Like I said, hospital, I was in the ER for, I don't know, 2 hours, 3 hours, $6,000. And another one, I was at $8,000. I was like, damn, what the hell they do for me for $8,000? It is so expensive. Number one cause of bankruptcy in America is hospital bills. So, I mean, forget the ICU stress, the cashier stress, that's the big one. So anyway, but anyway, just so you know how stress also occurs. Any questions? IBS all connects. All right, good. Good place to take our break. All right, then we go to gastric pathology, 10:15, we start at 10:40.
No, that's what you like. I didn't know. I didn't care.
Yeah, around the. With their break. Just.
Yeah.
That's why it's gonna be. Like doing a. Maybe just. There's all that. I forgot. Oh, no. They were the worst one. Okay, get it? Oh, were you here for the KG? Yeah, I think I got the last part about tall, wide, something, right? Yeah, it was B1, tall, wide, B1, and then the short, wide. Yeah, I think I need to get good on that. Yeah. B1. Yeah. You do it really fast. I love that. I think it would be in Thailand and I know that. But then you're thinking about. Yeah, I think about that. My God, there's you. Well, it's not super fun. Yeah. Sugar gets everywhere. Yeah. Go ahead. I was like so tired of buying one thing. Every break I'm in. Why?
No way. Like the last time I went out. Didn't show up. Yeah, he is. Oh, no. Ah, yeah, bro, that was. But that's, at least that's. Yes, that is. That's nice. Like, I'm a great team. If you don't have $5, so where do you fund? We lost. I don't know. Most games, always. That's yeah. Oh, cool. So, Really? The things. Yeah. Oh.
I love it.
I got one of those. You know. Yeah.
Yeah, I don't see the thanks for it. Okay, maybe not.
He's a pretty good info. Oh, you sound cool. But I. So the. I'm excited. Bueno. It's working ways. I mean, if you're working like 4 or 5 hours extra. This. Well, I'm yeah, yeah. But I want to be a surgeon. I don't want to be a fire. Bro, like this right here, so here.
What they really. I wonder where it's going now. I'm right here. Yeah, I am. Yeah, I'm sorry for the money thing. But function really say, hey. Yeah. We're so sorry. Oh, you just got it. I was just sitting on the couch waiting for things to come down. I was like, he left. I was like, you leave. You're like, yes. Like, I feel that. Yeah. The library.
You're welcome. What does it say? Yeah. And then they're gonna get. Jackie. Yeah. Yeah, yes. Yeah.
It's time.
All right, let's continue. Now we finish the stomach, let's go to gastric pathology. When things go wrong, gastritis is the most common stomach problem. Why? Because anybody can get it. You get it from hot, spicy foods, but mostly medication, aspirins, NSAIDs, steroids. All right, because again, remember, most of everything we eat and drink are acids. So if you eat or drink too much of it, it can burn your stomach lining. All right, so this is the most common cause of upper GI bleeding in children and adults. An ulcer, gastritis is superficial erosion. An ulcer is deeper. So type A gastritis located in the body, type B located in the antrum. Go through two of them. Type A has a series of A for autoimmune etiology, A for anti-parietal cell antibody, A for atrophic gastritis, A for adenocarcinoma risk. Stomach gastritis has a 20% risk of cancer. This is why when somebody comes in with symptoms of gastric ulcer or gastritis, we scope them. Okay, because we don't want to miss a cancer. 20% is too large a number. Whereas if you got a duodenal ulcer history, nah, we say just treat them. Gastritis. Type B gastritis located in the antrum. Remember, the antrum is where you sweep everything you eat straight over there to stimulate the G cells. Okay, and this is the one that makes sense with the pills. That means the pill will sit in the antrum for a long time and then burn a hole in your antrum. Okay, so this is due to a breakdown in barrier. Every book calls them, peptic ulcer disease, so students think it also has to do with too much acid. It doesn't. Type B is a breakdown in barrier, not from too much acid. Type A is from too much acid burning the hole that you already had. Type B associated with H. pylori. H. pylori is one of only 4 curved rods. Big clue. H. pylori, silver stains. It's the only one that silver stains in the stomach. And I think we talked once about treating it. We'll talk about it again next week, but the treatment right now is called an AOC regimen. All right, amoxicillin, omeprazole, and clarithromycin. AOC. Best way to diagnose this is urea breath test. If you have one of those machines in your hospital, my hospital didn't have it. So we always scoped them and cultured it, which is okay as well. But now with PCR, you can do PCR. PCR can detect anything. So they now have a PCR test for it. It's very specific. H. pylori. We'll talk about it more next week. Peptic ulcer disease. If you say ulcer, that's deeper than gastritis, just so you know, it's the depth. If it's just mucosal, we say gastritis. If it's down to submucosal, we say ulcer. Gastric ulcer, pain is worse during the meal. Located in antrum, like I just explained. Associated with H. pylori 70% of the time, but associated with cancer 20% of the time, which is why we scope all of them. Gastric ulcers. Duodenal ulcers, pain is worse 30 to 40 minutes after a meal. Because like I explained earlier, that's how long it takes for food to hit your duodenum, so it makes sense. Now you pour acid on that naked hole there, and that's why it hurts right after that meal. Or it hurts more at night. Why? Because you have no food in your stomach to absorb acid. And so it starts to burn again. Usually located at the second part of the duodenum. That's because when food pours out of the pylorus, it drops straight to the second part. Associated with H. pylori 95% of the time. So H. pylori is associated with duodenum more than gastric. They say treat them at least with 2 drugs before you scope them. Because the yield of endoscopy is too low. That means only after they fail at least 2 drugs. You say, okay, well, let's scope them. Make sure nothing bad is going on. Only 1% of the time would you see an ulcer. Okay, and we'll talk about the drugs at the end. Peptic ulcer disease, when do we do surgery? The mnemonic is IHOP, International House of Pancakes. I for intractable pain. H for hemorrhage. O for obstruction from scarring. And P for perforation. So the 4 reasons why we take peptic ulcer to surgery. Any questions so far?
Yes, I have a question, sir.
All right, Mabel,
So,
question?
yeah, please, when did you say it is called ulcer or peptic disease?
It's called an ulcer when it gets down to the submucosa. Has to do with the depth. Gastritis is only the mucosa. You understand that, Mabel?
Yes, sir. What about disease? When is it called disease?
What means it called disease?
Okay. Sorry.
What disease are you talking about?
Okay, maybe I misunderstood. I'm good.
Yeah,
Thank you.
I said it's called gastritis versus ulcer. It has
Okay.
to do with the depth. Yeah.
All right.
If we say peptic ulcer disease, a disease just means it affects one organ. It's only affecting one organ. Yeah, that one's already defined. That's why I was figuring she was asking about something else. All right, Syed, you have a question?
Just a quick question on the word intractable. Does that mean like not like the pain isn't reducible or?
Yeah, exactly. That means they still have a real bad pain that messes up their day, and we've got them on at least 2 medications and they fail both times.
Okay, thank you.
Yeah. If I give you an H2 blocker PPI, within 4 weeks, you should be almost back to normal. If you're not, it means the drug's not working. Okay, usually by the end of the first week, the person should be at least feeling some kind of relief. Yeah, intractable means weeks later, still the pain is there, it hasn't changed. Bezoars, what's a bezoar? The definition of a bezoar is a mass made of undigestible material. Like when a child eats a Barbie doll shoe. You know, every now and then they'll swallow one of those. That's a bezoar. But the most common type is hair. Trichotillomaniacs. little boys and girls, mostly little girls, who pull their hair as a nervous habit while they're playing something or talking, they're pulling their hair with their finger. They don't realize they're wrapping it tighter and tighter, and they just pull it right off. All right, but then if the finger comes close to their mouth, the hair crawls right in. And they have no idea how much hair is in their stomach. Until one day it wraps around some stuff that they ate, and now it's stuck in the pylorus and won't move. Now we got to scope them and get it out of there. Yeah, so bezoars have to be scoped and removed because it won't move. And you cannot digest it, so it's not like you just leave it there and let it be digested. So bezor. Hiatal hernia. What is a hiatal hernia? It's a hernia through the esophageal hiatus or the diaphragm. Remember, a hernia, Steve, as I explained to you earlier, means one tissue going through another tissue. So in this case, it's a stomach going through the diaphragm. So one tissue going through another tissue. So two types, 90% of the time it's called sliding type hiatal hernia. What is this from? The fundus of the stomach sliding through the esophageal hiatus. And then it gets stuck in your pleural cavity. It's not supposed to be up there. So sliding of the fundus into the esophageal hiatus. Most common cause, obesity. So you know they're gonna ask you. That's because when somebody's obese, then every time they sit down, the abdominal pressure goes way up. And that's gonna push things upward. And then if there's enough negative pressure in the thorax, it'll push right in there. So obesity is number one, vesicular lung disease is number two. Treatment, we start conservatively with H2 blockers and PPIs. Okay. Obviously, we try to get them to lose weight, exercise. Okay, don't eat late at night. Don't eat after 8 p.m. And then surgery if necessary. The surgery we used to do was called Nissen fundoplication. What that meant, I said, they go down there and take the fundus of your stomach. So here's the opening on the diaphragm to the pleural cavity up here, stomach down there, abdomen down here. Everybody follow me? I'm going to take the fundus of your stomach down here and wrap it around the esophagus down here. That means now you got a bulge. Guess what? Nothing can fit through that hole. You just wrapped up the hole. Then we ran into trouble. We didn't know what was going to happen. It seemed like a great procedure. And I mean, when I was the resident back in the 80s, man, we were doing 8 or 10 of them a day. Children with reflux, babies with reflux, Nissen. My baby's got too much reflux, Nissen. And then as time went, that means the children got older, we run into problems. The problem was you cannot belch. You don't have to vacuum the belch. Like if you drink Coca Pepsi real fast, CO2 gas is produced right away. What do? And you let it out. If I do a Nissen, you can't let it out. You don't have to let that bubble of gas work its way all the way out to the other end 6 hours later. So the children were in agony just from drinking Coca Pepsi, a bubble that just won't go. Okay, now you wait next 4 hours, 6 hours, they're in pain because that gas won't go anywhere. That's why we don't do that anymore, unless you are forced to. I mean, I used to see 10, 12 Nissens on the schedule every day when I was a resident. Now you don't see one for months. Okay, it's only when the surgeon is forced to. That means you got to have a conversation with the person. There may be a chance you may be able to belch, but I mean, if things are bad enough, then they probably will put up with it. But for the other person, no, you don't want to do that. All right. So sliding hiatal hernias will increase high incidence of GERD because now your stomach is up in your thoracic cavity. Rolling type is the dangerous one. For this one, actually, there's a tear, an actual rip in the diaphragm, and then a piece of the stomach got sucked up there because of the vacuum. The problem is that could get stuck there. That's called strangulation. Yeah, you never want to leave that up there. That one, you have to do surgery quickly. All right, so there's a defect in the diaphragm. It requires surgery for all of them. The risk of strangulation and infarction is what we're worried about because you create a bottleneck there. Okay, any questions on hiatal hernias? Meniere's disease. Not very common, but they love to test it. Meniere's disease, you see large rugal folds in the stomach. They love to ask, what are you going to see in the stomach? That's what you see. Big rugal folds, but you got more goblet cells than normal. That's why they got so much mucus being produced. But that mucus is full of protein. So they're losing the protein in their stool. So it's the same thing. It looks like you got nephrotic syndrome, except the kidney's just fine. Okay, albumin very low. And they're swollen all over because they hardly have any oncotic pressure and so forth. But the problem's in the stomach, and all you do is cut it out or cut some of it out. Adam? A rolling hiatal hernia involves a hole in the diaphragm, whereas a diaphragmatic hernia, which is this question, means a rip in the diaphragm on the side, which means a ton of intestine can go up in the thoracic cavity. This is only the stomach, because the stomach is the only one that's close to that hole. Yeah, so the structure involved makes it easier to separate. Pyloric stenosis, always on exam. Remember, hypertrophy of the pyloric muscle presents around 3 to 4 weeks of life. Why? It takes that long for the muscle to get hypertrophied enough that it starts pushing everything backwards. And that's how you get the projectile vomiting. Classic, nobody should miss that one. Projectile vomiting. Yes. Is Mediterranean's disease and sort of gastric surgery? Not necessarily, no, it's a genetic problem. Yeah, I haven't seen that. Yeah, I've seen that genetic reason. Our Olive sign is we feed the baby and you put your finger in the right upper quadrant, Melissa, and you can feel the pylorus roll underneath your finger. That's the Olive sign. String sign is when we used to do a barium minimum, a barium swallow. We make them swallow the barium, and you see this little string of barium light that goes through the stricture or the tight area. We don't do that anymore. We just do an ultrasound. No radiation, no pain. And you can see it. What do? Correct the fluids and electrolytes first, and then do surgery. Pyloric myotomy means split some of the fibers. Because this person is vomiting for several days, Matt, when I check, here's her electrolytes. The sodium will be what? High, low, or normal? Low, why is it low? You're saying you're vomiting sodium out? Yeah. Yeah, a little bit, but that's not the main reason. Anybody know what the main reason is? Jess? How do I get sodium to be low? Is my question. That explains alkalosis. You explain alkalosis, but it's not explaining hyponatremia. Yeah. You explain that alkalosis, which is okay. So for that, yes, but that doesn't explain hyponatremia though. Oxane. Decreased concentration. What outside?
Sorry.
Exercise potential goes down. I'm still trying to explain hyponatremia. Nobody's done that yet. Melissa, how would you explain it? It's called low volume state. Yeah, I like easy, folks. Why don't you just tell me that? Low volume state, low sodium, low chloride, low calcium, low potassium, metabolic alkalosis. Look it up. I told you they're just going to call it something different every time they answer that. And if you don't see it's the same thing, you're going to be thinking real hard. And I realize it's an easy question. This is just with a whole lot of volume. We put them in the house with electrolytes messed up because hypoclemia can kill you. Okay, but they'll ask you, what are the electrolytes going to show? It's just sitting as a low volume state. They're vomiting. You're losing volume. I expect your body to respond the same way again. Okay? All right. Pyloric stenosis. Summary thus far. What have we done? Protein. No protein digested in the mouth, but significant protein digested in the stomach. That's called renin. Not renin, sorry, pepsin. And we're going to complete the small bowel. What about sugars? Significant digestion in the mouth, that was cell amylase. But it's small in the stomach, the cell amylase got denatured. Then we're going to finish the rest in the GI tract. Everybody still with me? And in fact, there was only 1% digestion in the mouth by cell lipase. That means 99% of your fats will be digested in the small bowel. But you cannot digest fats in the stomach because lipase gets denatured as well. Any questions on where we're at? We're about to empty your stomach into the duodenum. Let's go, small bowel. After food digests in the stomach, we now call it chyme. So you gotta know the right word. See, that way when they use that word, I told you, different words tell me what part of bowel we're talking about. And you can rack up a lot of points because the test writer never thought you'd use those words against them, and it works. That's what you're saying? I see a hand up. No? Okay. All right, here we go. Hormones involved in the stomach. As you see, this is a review. Pay attention though, you've heard it before. Ghrelin. Secreted by the walls of the stomach in response to distension. So when the stomach is empty, ghrelin comes out, stimulates the hunger center in your hypothalamus, that lateral medial, lateral. All right, leptin. Stimulated by, it's produced by the walls of the adipose cells. It responds primarily to distension. So when adipose cells distend, it means you're full. Leptin goes up the satiety center. Where's that at? Medial hypothalamus. That's why you feel full. Any questions on them? So this is a lot of new information hitting the literature now, so that's why they're starting to ask it. Do we do no hormones? We've gone through all of these. Let's do it one more time. Justin. What's that? Can you give leptin as a weight loss drug? Is that what you're saying? Sure you can. They're experimenting with it. Yeah, right now it's not been approved as one, but they're trying to see if it will actually work. So do we do no hormones? Secretin, S cells. Right? Main stimulus, again, this is all from endocrine, there's nothing new. All right, main stimulus was when, low pH hits your duodenum. Inhibition, high pH, which means you're done digestion. Where does it go? Paracrine, doesn't go far. It goes to the pancreas and gallbladder. It causes secretion of bicarbonate. That's its main job. It's to neutralize the acids that dumped into the duodenum. Second messenger, psychic AMP. The other two actions that it has, slow down gastric emptying. In other words, you say, hey, slow down, let me finish this. Neutralizing this before you send me any more. And number two, inhibits gastric. Again, you say, hey, it's a lot of acid here. Just slow down on that gastric. Make my job easier. So bicarb is its main function. Every time I see the question, bicarb. A couple of times they ask about the other stuff. But again, we've talked about all three. CCK from the eye cells. Paracrine again, main stimulus, food in the duodenum, especially fats. Remember, fats need the most digestion, so the hormone dedicated to them. Fats. What's it going to do? Go to the pancreas and cause release of pancreatic enzymes. We've talked about all of them in biochemistry. Then it goes to the gallbladder, squeeze the gallbladder and say, hey, dump the bile salts, and lecithin. I need that to finish digestion. Any questions on CCK? All right, third one, motilin. Motilin, secreted by the endothelial cells, the muscle cells themselves. All right, so during the meal, stimulated by acetylcholine. In between meals, stimulated by distension. That's why you have peristalsis going on in your gut at all times. Okay? Small bowel is the last time we will ever use the term primary and secondary peristalsis. Okay? Because it actually changes names. So if they just say peristalsis, that's going to be esophagus and stomach. In the small bowel, primary peristalsis is called segmentation. Remember, I told you, certain terms, tell me exactly which part of the bowel they're talking about. Here's another one. They mentioned segmentation, you can only be talking about small bowel. If you remember, small bowel has all these little lines in it. That's the second. Secondary peristalsis is called MMC, migrating mesenteric complex. Because you always have food still left over and it sets up another wave and keep pushing things further. Says motilin. GIP, right? Insulin, potassium, for the K cells. No, was it? Yeah, K cells, okay. Make sure I had to file away properly. So GIP. GIP is also known as an incretin, a term you've heard before. And what do incretins do? They go to the what organ? Ida. Where do incretins go? Not liver. Where do incretins go? On pancreas. Their job is to inhibit glucagon because you just ate some sugar, and then promote insulin release. As I remember that. And then incretins are inhibited by, remember, DPP4, dipeptidopeptidase 4. How do I know an incretin mimetic drug? What does it sound like? Lauren? How do I recognize an incretin mimetic drug? What does it sound like? No, not left hand. Let me ask Sandra. How do you recognize an incretin mimetic drug? What? Not gliptins. Montessori. Let's ask Paul. Let's ask Raimundo. Yeah, I rolled it a little bit. That was good. That's pretty good. I was trying to remember what you did. All right. Do you know this one? All right, Cesar? No, not gliptins. Melissa? The tides. I told you I'm on exenatide, liraglutide, demaglutide, semaglutide. There's about 5 of them. They all end in tide. The gliptins are TPP4 blockers. Now they inhibit the breakdown of the ingredients, but make sure you keep them straight. Okay? All right, anyway, that works into GIP. VIP and somatostatin are counter-regulatory. Their job is to make sure the other hormones don't get out of hand. So they come out when the other guys come out. They go home when the other guys go home. They're purely inhibitory. VIP comes from Auerbach's plexus. That they will ask you. Somatostatin comes from the D cells. They both have cyclic AMP as their second messenger. And then the first enzyme to be released for the duodenum is called enterokinase. What does enterokinase do? It activates the very first trypsinogen to trypsin reaction. And then trypsin will activate every enzyme after that. One more time, Kathleen. Enterokinase activates the very first trypsinogen to trypsin reaction. And then trypsin activates every enzyme after that. Hey, wait a minute, Kathleen. What cofactor does this kinase use? Do you remember that? How do you know that? Because every kinase uses magnesium. That's how you know that. Yes, so this kinase uses magnesium too. All right. Pancreatic enzymes, next thing to discuss. Yes, sir. Yeah, enteropeptidase, enterokinase are the same enzyme. Yeah, you can name it either way. Pancreatic enzymes. Again, we've done these back in biochemistry. They come as zymogens. Zymogens means inactive form. So trypsinogen, chymotrypsinogen. Okay, they're not active because if you let them be active, you digest your own pancreas. All right. So zymogens are inactive forms of the enzymes. The first trypsin is activated by enterokinase, and then trypsin activates all of their enzymes. There's the same list you've seen before. Remember, trypsin cuts the right of lysine arginine. Take a trip to LA. So I told you, remember it? Chymotrypsin cuts the rate of the 3 bulky amino acids: phenylalanine, tyrosine, tryptophan. Which one of those amino acids Metro used to make catecholamines? No, not tryptophan. Tyrosine is used to make catecholamines. Tryptophan is for serotonin, which is going to be an expression. All right, elastase, you need gas to last. Remember that. Glycine, alanine, serine, gas to last. Elastase cuts right those 3 smallest amino acids. Which one of those 3 is the smallest amino acid? Just glycine. Aminopeptidase cuts to the right of anybody on the amino terminal, and then carboxypeptidase is the only one who cuts to the left of anybody on the carboxy terminal, which is all the way to the right. And then you have pro-amylase and pro-lipase. Again, inactive forms. Amylase, oh, wait a minute. We're going to digest sugars first. We're going to digest one thing at a time. Amylase breaks down alpha-1,4 glycosidic bonds. And so now you got a bunch of disaccharides. Lactose, sucrose, maltose, alpha-dex. Alpha-dex is a branch point with the alpha-1,6 bond on it. So lactose, remember, is glucose and galactose. Sucrose is glucose and fructose. Maltose is 2 glucoses with alpha-1,4 between them. And then alpha-dextrin is 2 glucoses with alpha-1,6. So it's the branch point. You understand, Kathleen? You understand, Austin? All right. If you guys remember, fructose is the only sugar with its own transport system. You guys remember, fructose is completely unregulated. That means if you have enzyme deficiencies or inflamed bombs, what sugar can still be absorbed? Kathleen? Fructose. Everybody understand that? Yeah. You guys ever heard of apple juice diet we use in children? When a child has gastritis, why do we say, Mom, just give us some fructose? You know, that's what we're talking about. Because even though when you get gastritis, the lining sloughs off. Because remember the response to hypovolemia? You lose blood flow to the GI tract. That lining sloughs off. That means all the enzymes are gone. But you can still absorb fructose. That's what the apple juice diet is all about. All right. Lactase is the first enzyme to disappear and the last one to come back. It only takes 48 hours though. But for those 2 days, we just tell Mom, just feed him some, fruit juice, and he can absorb it just fine. Yes, sir.
Any reason why pear juice is better than
Why is pear juice better than apple juice? It's just because pear juice has some sorbitol to kind of clean things out. I mean, including the virus too. Yeah. All right. So fructose, the only sugar has its own transport system. Otherwise, if I were to ask you, how do you absorb glucose or any sugar in the duodenum? In the latter 1/3. Anybody remember how to do this? Oh, Cena got her hand up first. How you do it? Oh, don't yell at me if I get it wrong. Well, it's glucose transfer protein, so I'll give you credit for that. All right, remember I told you how to figure this out. Listen again. I said, what do you do? Ask yourself, is it a small ion? No, it's not a channel. Is it sweat? It ain't pores. What's left? Transport protein. All you gotta do is ask yourself, are you gonna guess a gradient? No, it's not ATPase then. Then it must be sodium co-transport. Look at your nose, baby. I told you. We'll get to GI. You guys swear I'm talking about GI. You can learn that in memory phase. Okay, but you got to remember it. Now we got to apply it. Otherwise, you guys want me to talk about it. No, I'm not going to talk about it. I'll just point out it's in your notes already. Okay, there it is. All sugars covered. I'm done. Okay, that's why it doesn't take so long, folks, because we've already covered most of it. All right, anyway, that's amylase. Disaccharidases, lactase, sucrase, maltase, alpha dextrinase. See, you just need an enzyme that breaks them all down to free sugars. Sucrase deficiency is the most common primary disaccharidase deficiency, meaning 10% of the world population cannot digest sugar. It is the most common congenital disaccharidase deficiency. Remember, sugar is the most common addiction in the world. So imagine 10% of people can't eat sugar at all. Lactase is the most common secondary, meaning you end up with gastritis from whatever bug. The lining will slough off, but then you develop a lactase deficiency because he's the last one to come back in. That's why if you give that child milk right after gastro, he's going to have even worse diarrhea because he has no lactase. Okay, that's why we say drink fruit juice for a couple of days. First enzyme to leave, last enzyme to come back in 48 hours. Any questions on disaccharadases? Again, all the free sugars, sodium co-transport, every one of them except fructose. Next, pancreatitis. The most common cause of pancreatitis, everybody better know this, we've rehearsed it many, many times. This is the most common severe abdominal pain. I introduced you to that. The pain is mid-epigastric, born through your back, because pancreas is retroperitoneal. Most common cause in children, remember, trauma for children, followed by infections, Coxsackie B and mumps. Then high triglycerides number 3, high calcium number 4. In adults, most common cause was gallstones. Remember, alcohol has been bumped down to number 2. Then high triglycerides and high calcium. Any questions on that? All right. Pancreatitis, complications of pancreatitis. First one's called a phlegmon. Phlegmon is when the pancreas is so inflamed that your intestines wrap around it to try to contain the inflammation. Folks, they didn't know that the intestines had sensors on their surface till this happened. This is decades ago. Because they kept seeing people with pancreatitis and the entire intestine was wrapped around the pancreas. And they started thinking, well, how did the intestines know the pancreas is inflamed? It has sensors on it. So they did a study. They poked a little hole in people's belly, put a little puff of air in it. Because air in the abdominal cavity signals you got perforation and inflammation has begun. All of a sudden on camera, you can see the intestines start wiggling towards that puff of air and wrap around it and keep it contained. That is amazing. The intestines can tell when something has happened and they start crawling towards it and keep wrapped up, okay? And phlegmon comes from the word phlegm. Phlegm, slow movement, because once it wraps around that intestine, it's not gonna move, okay? The problem though, what's the first visible sign of inflammation due to pancreatitis? Bailey. Swelling. That means your intestines can swell up with a whole lot of water. This is why pancreatitis can cause severe dehydration and the person hasn't even vomited once yet. And they'll ask you, how did this happen? It's in the intestinal wall. If you remember, we talked about this in glycogen synthesis while I was talking about it. The intestinal wall produces its own glycogen. And as long as you're squeezing, you got peristalsis, no problem. If you got the ileus, like here, the wall just starts swelling up with a whole lot of water, and now it's not moving anymore. The person goes to shock, dehydration, hypovolemic shock, and yet they haven't vomited and pooped and peed. Okay, so watch out for that. So it can cause a severe ileus, now you know how. Severe dehydration, now you know how. What fluid you want to start them on, Melissa? Yeah, normal saline, automatically, because we know they can dehydrate even though they've not been vomiting. You don't wait. Say, well, he's okay, he's not vomiting. That's not where the dehydration comes from. You got to start it as they come to the ER because they're going to get dehydrated. Ramsay's criteria is criteria for poor prognosis on presentation and after 24 hours. Now I'm going to show you how it makes sense of this stuff. Age above 55, this is on presentation. Age above 55 is because they have other comorbidities, diabetes, obesity, hypertension. They got other things I got to worry about. Blood sugar rises above 200. It means the enzymes have already digested your islet cells. You're diabetic now. If you're diabetic, new onset diabetes with high blood sugar, and you go to the hospital where all the germs live, you're going to pick up sepsis. That's what they mean by poor prognosis if any of these things happen. Number 3, white count above 16,000. That means there's a lot of severe inflammation going on. And then the same thing with these enzymes. LDH and AST are leaking out. That means cells are dying. And remember, the higher the number, the worse the prognosis. Any questions on these 5 criteria? Again, make sense of it so you're not just memorizing 5 things. All right, because I don't memorize that, but if I see it on a test, I say, oh yeah, that's right. I remember it. That's from inflammation. Adam. Right, the dehydration can occur when because they have a lot of vomiting, or it can occur because they have a phlegmon. Yep, either one. Poor prognosis in 24 hours, if what? There's 4 criteria for that. If the patient needs more than 6 liters of fluid, that means you had a lot of thirst facing the walls of the intestine. The average person only needs 3 liters of water a day. So if you got to give 6 liters, whoo, that's severe ileus. That's severe ileus. Okay, that's why poor prognosis. PO2, less than 55, means they develop ARDS. How does that happen, Angie? Because the enzymes made their way to your lungs, ate holes in it, and fluid leaked out and washed away your surfactant. ARDS has a 60% mortality rate. So we're not talking about small numbers here. The lungs get so stiff, you can't even ventilate. Third, hemoglobin drops by 2 or more grams. That's because you're bleeding into your pancreas. Remember, pancreas is retroperitoneal? So you get retroperitoneal hemorrhage. Anybody remember a sign of retroperitoneal hemorrhage that we talked about? Adam? Yeah, great turn in when you come around the flank. Color when it's right here in the middle, around the umbilicus. Yeah, so they'll give you those clues. Okay, but bad. If you don't catch it, they'll bleed to death and you don't even know they're bleeding. And if calcium drops to below 8, it means you got saponification, fat necrosis. Remember we talked about that. Pancreatitis, no more cause of fat necrosis in the abdomen. Any questions on these criteria for poor prognosis? Again, make sense of it. Please don't just memorize it. Yes, Lauren. ARDS is because enzymes, elastase, it's gotten loose. Yeah, so it digested the vessels in your lung, and now fluid leaked out and washed away the surfactant. 60% mortality. Hemorrhagic pancreatitis has 40% mortality because I had one of my patients had it. Management for pancreatitis. Hopefully you guys remember the 5 things I told you got to do for everybody. Before you worry about why they're here, don't forget NPO because I got to take you to surgery. NG tube to compress the gas so they don't perforate. IV normal saline because they may go into shock. Meperidine for the pain because it allows gallstones to pass freely. And then abdominal x-ray. Any questions on that? All right, so again.
Yes,
so
yes, sir.
Yes, ma'am.
Well, why do we have to give them neoperoral and also NG tube? Is it for regurgitation, for aspiration?
No. NPO, I said, in case I got to take you to surgery. I can't let you eat and then take you to surgery. You're gonna vomit and aspirate and die.
Okay.
Yeah. And nasogastric tube is decompress all the gas that builds up when your gut's not moving. That's what causes it to perforate.
Okay.
Yeah. All right. Hemorrhagic pancreatitis, like I told you, 40% mortality, but you got two good physical findings, Ray Turner Center Cullen sign that we've talked about before, and you're gonna have to cut out some of that pancreas to save that person's life. Remember, there's a ton of blood supply around your pancreas. Pseudocyst is another long-term complication. If you're somebody who's already recovered from pancreatitis, but then they still have this kind of non-specific fullness in their belly. It's actually a big bubble. They call it a pseudocyst because there's no real epithelial lining. A true cyst has epithelium in it. This one doesn't. It looks like a clear bubble. You do an ultrasound, you just see a bubble of liquid. Okay? The problem is sometimes it can become infected. And now you got a huge abscess. In the old days, folks, they used to connect that cyst to the small bowel, let it drain in and just flush their intestines for a minute, we'll get a benefit out of it. All right? That's what we do now. Sorry, that's what we do now. In the old days, they used to hook it to your skin. I said, who came up with this? If you get to my skin, that means there's fluid leaking all over my skin all day long. That means my clothes are getting soaked. It was the craziest way to do it. So somebody came along, no, let's look at the bowel. Let's flush the bowel out. They get another benefit from it. So that's why now it's called cystoenterostomy. Remember, you just say the name of the two things. Ostomy means you're connecting the two together. Okay? Persistent high amylase is another clue that you got a pseudocyst. Gallstones is old stuff. Remember I told you, you've gone through this before, but I'm going to review it again for you. I said there's three sides to a gallstone: high cholesterol, or not enough less than a bowel salts. Burkhouse triangle. There's the three ways to have a gallstone. And for that reason, iodinodes, the majority of gallstones are made out of what? Cholesterol. So they're clear or yellow. When they're green and black, they're made out of what? Bilirubin. So yeah, I almost spread ahead of you. So you got to pick a hemolytic anemia now, okay? Because they'd love to ask, what's causing this? You got to pick a hemolytic anemia. That's black or green. And when they're brown, infection, Salmonella or E. coli. Okay. So if you have low lecithin or low bowel salts or high cholesterol, you're guaranteed to get gallstones eventually. Presentation. The classic ones. Right of aquatic colic. Remember, stones slide slowly. So that's why the pain comes in waves. Every time the stone slides, the smooth muscle grabs it real hard. And that's why the person screams like crazy until the muscle spasm releases and then the pain goes away. That's why they talk about crescendo colic. Okay, it comes in waves. Murphy sign. I ask you to inhale. And then I start pushing up in your right upper quadrant. As you're inhaling, your diaphragm is pushing your gallbladder down, and my hand's gonna meet it. And the person will grab your hand immediately because that gallbladder is inflamed. So again, these are specific signs that a person has cholecystitis or gallbladder disease. All the other stuff, nausea, vomiting, won't get you any points. Okay, because every intestinal problem has nausea, vomiting. All right. And then right upper quadrant pain, worse after eating a fatty meal. Is because of what hormone, Gustavo? No, gallstone pain. Right upper quadrant pain, worse after eating a fatty meal. And the reason is due to a hormone. CCK. Because CCK is going to squeeze gallbladder to push things in, and there's a rock in the way. And all that stuff goes right back into the gallbladder, and distension hurts like crazy. Those are the three most specific signs that you have a gallbladder problem. Any questions on that? Remember, all you need is one of them, and you should know what the person has. All right, and E. coli and salmonella for infections. All right, 80% are made out of cholesterol, 20% are made out of calcium bilirubin. So those are black and green, like I said. 90% get large in cystic duct. And then just under 10% get lodged in the common bile duct. If you remember, we drilled it this morning. 3 clues for common bile duct stones. Pancreatitis, because the pancreatic duct drains into the common bile duct. High alkaline phosphatase, the biliary tract cells release alkaline phosphatase as they die. And then high white count of fever, because you have a column of pus as the equivalent of an abscess. Any questions on that? And knife. The rare gallstone could cause a gallstone ileus. And when you looked at the abdominal x-ray, you have what we call pneumobilia. Where is the gallstone trapped, sir? I don't know where between the small bowel and large bowel means. And Melissa, you remember this? If you have pneumobilia, where's the gallstone stuck? All right, Ashley? It went into the duodenum, that's not where it's trapped though. It's trapped at the ileocecal valve. It just rolls downhill. Gravity will push it down. But then it can't go to a sphincter because it can't roll sideways. It's just stuck. All right, so watch out for that. That's just a rare case, but it's so classic finding. I diagnose of gallstones. We always do after those 5 things, just about x-ray, ultrasound. Ultrasound can find a stone, tell you where it's at. You'll see the dilation of the ducts proximal to it, okay? If the ultrasound does not find it, then you proceed to a HIDA scan, which I discussed earlier. You give them a little radioactive dye, it's supposed to be taken up by the liver, which is the gallbladder. If you got a rock in the cystic duct, it cannot get into the gallbladder. So they'll say non-visualization, which means it's a positive test. So ultrasound is negative, you proceed to HIDA scan. We don't do OCGs anymore. This is oral cholecystogram. That's because they have so much nausea and vomiting. When you give them the dye to drink, they just vomit all back up. So nobody does it anymore. All right. If you want to go in and get the gallstone out of the biliary tract, what do? What is it called? It's called ERCP. We're going to go in there with endoscope. Got a little hook, pull the stone right out of there. So ERCP is when you want to retrieve gallstones trapped in the biliary tract. But if they cannot tolerate ERCP, remember I said do MRCP. You can at least see where the stone is. But you just can't pull it out. So ERCP is done to retrieve biliary tract stones. Best treatment is laparoscopic cholecystectomy. Remember I told you the study showed is best done within the first 7 days. We don't wait anymore like we used to now. If they got cholecystitis, remember I said IV antibiotics was like 2 or 3 days, taking a surgery, cholecystectomy. That way it's out before 7 days for the best results. Ursodeoxycholic acid is given for the person who cannot go to surgery. It's usually some little old lady, she got so many medical problems, she probably dies as soon as you knock her out with anesthesia, so we don't do it. We just give her some of this, so melt some of that gallstone, so it can just stay there for a little longer, okay? So ursodeoxycholic acid is only when surgery cannot be done. Asymptomatic gallstones, we schedule to take them out sometime within the next 2 years. I told you, if you follow these women for 2 years, because most of these women, 65% are gonna have an attack in the next 2 years. So they say, take it out, but it's not an emergency. You say, okay, ma'am, why don't we plan on taking it 3 months, 6 months? Which one works out better for you? And she'll tell you, and then we take it out. What does the term choledocholithiasis mean, Karina?
So there's a stone in. Okay, so it's. I'm freezing up.
You got the lithiasis part, that's a stone, but where's it stuck?
It's stuck in.
Raimundo. Raimundo, where's it stuck? Huh? Choledochal, no, biliary tract, yes, it's biliary tract. It means it's stuck in the bile ducts. Choledocholithiasis. Cholangitis, what does that mean, Chris? Yeah, it means the infection is in the biliary tract now, okay? All right, so again, they're all been fat absorption. So we've done sugars. Any questions? Now we're gonna absorb fats, okay? So to absorb fats, folks, You release pancreatic lipase, right? Pancreatic lipase will digest your fats for you, but you have to form a micelle. Here's a picture of a micelle. Micelle is bile salts and lecithin surrounding a core of fat. So the hydrophobic end goes into the fat, and then you pull it apart with the hydrophilic end. That way you form a monolayer with that fat. Because remember, fat likes to clump up. Well, the enzyme can't climb up the mountain. You gotta make that fat a monolayer. That way the enzymes can coming from 1,000 different directions. Any questions on that? So lecithin and bile salts are used to emulsify your fat. We call it a micelle. So you got a picture here, okay? And we're gonna use that to absorb our fats. So pancreatic lipase. How can I inhibit pancreatic lipase and therefore decrease how much fat you can absorb? Ange. Excuse me? Yeah, remember Orlistat was the drug I gave you. Over the counter right now as Ally, right? Prevents pancreatic lipase, so you digest less fats and therefore absorb less fat. Lecithin helps emulsify your fats. This is just another name for phosphatidylcholine. And if you modify, you can make surfactant out of it, so you've heard it before. Bile salts start out as bile acids. Cholic and chenodeoxycholic are bile acids. And then when they conjugate to something, which is glycine and taurine, then we call them bile salts. So that would be glycocholic or glycokenodeoxycholic, and then taurocholic or taurocenodeoxycholic. So that's how I know when it's a salt. It's got to be conjugated to be called a salt. They also help emulsify. Here's how you absorb bile salts. All right, so here we go. Everybody follow me, my arrow. I'm gonna start out here in the duodenum. The bile from the gallbladder, squeeze, here comes everything into the duodenum. They surround this band of fat that you have, and then you're gonna digest it down with lipase. And when you digest it down, remember you now have short, medium, or long chain fatty acids. Which one does not require micelles, Andrew? Medium chain, hopefully everybody still remembers that. So even when you have terrible intestinal walls like Crohn's and celiac and all that, medium chain triglycerides can still be absorbed with no problem. But short and long require a micelle. What do you wrap around them? ApoB48. Hopefully this is sounding familiar. You've heard it before. ApoB48 wraps around it, and then you call it a chylomicron. Chylomicrons are gonna take the triglycerides primarily to where? Jess. B48 is used to make the chylomicrons. Where do chylomicrons take triglycerides to? Liver is the second place. Where's the first place? No, they enter the blood, but they're heading somewhere. Chylomicrons, let's ask someone. No, they got their own lymphatic channel. But where they headed for, Gloria? Endothelium is where 75% of triglycerides are going to. Remember I told you, in the test, you got to pick endothelium before liver. Liver is the remaining 25%. Okay, so chylomicrons. Then at the liver, the short, medium, and long will meet up. And then the liver will turn them all into long. What do we call it now? VLDL. VLDL then receives B100 from the liver, but he doesn't use it. But he gets C2 and E from whom, Mayha? VLDL gets C2 and E from somebody else. Give me a check with Zena. Now, lipoprotein lipase is the enzyme you have to activate later. Hendrick.
HDL.
HDL. Remember the man got a nice car? Selling everything out of his trunk. All right. So he picks up C2 and E from HDL, and then he goes where? Adipose, and stores half the triglyceride. Which one does he use? Which lipoprotein does he use? C2. Right? C2. C2 then activates lipoprotein lipase, and you store wheat triglycerides and adipose. Now you call him IDL. IDL uses ApoE to drop on triglycerides, E for everywhere else. So remember, chylomicrons go to endothelium, then liver, and VLDL goes to the adipose. Anywhere else, you say IDL drops it off. Give me a sign that you have very high triglycerides, Karis. Was that? Yeah, xanthelasma, and then remember recurrent pancreatitis, tendinopathies, right? All those are signs. First line drug for triglyceride problems. Austin. What? I can't hear you. Statins? No, statins for cholesterol. Triglycerides. Andres. Yeah, the fibrates. Remember, fibrosol, clofibrin, and fibrate. They activate lipase. That's how you store weight, triglycerides. Give me a drug that blocks VLDL production, Rachel. Maybe Kathleen? Maybe Adam? Niacin, the vitamin. Good. All right. That's just triglycerides. That's old news. Now let's come to new news. How you recycle bile salts themselves. All right, the bile salts you dumped into duodenum. All right. What the problem is, by the time you get to ileum, a lot of it gets deconjugated. That means the salt form, the toro, the glycol part falls off. That means it's back to being fat soluble, which means the ileum can pick it up. Okay. Typically, 80% of the bile salts are reabsorbed, 20% are excreted. If remember, bile salt excretion is number one way to lose cholesterol every day. Common question. What's the number one way your body gets rid of cholesterol? It's through bile salt excretion. That's why we have drugs that can bind up bile salts so that you excrete more of it. And therefore you lose cholesterol out of your body. Ebony. You know the name of this drug? All right, Mabel. Do you know the name of this drug?
Forza.
And what's the name of this drug?
Name of the drug to do what?
Oh boy. Mabel, make sure you're paying attention. I said the drugs that bind up the bile salts so that you excrete more. What's the name of those drugs? Can you name one of them?
Is it ezetimibe?
No, ezetimibe blocks the lacteals. How about Alvin?
Is it the bile acid resins?
And their names are?
Cholestyramine.
Okay, close enough. Cholestyramine and cholesterol are the two. All right. Now, when you reabsorb this bile salt, the 80% that you reabsorb, it enters the lymphatics and recirculates back to the liver. The liver then reconjugates it and pushes right back in again. So that means during the meal, you're not synthesizing any new bile salts at all. You're just recycling them. Because they love to ask, when do you have peak bile salt synthesis? It's in between meals. During the meal, you're just recycling. You don't have time to make it from scratch. But when you're not eating, then the liver can make some more for you. Any questions on that? All right.
Excuse me.
Yes, maybe.
You said that peak bile salt is syndrome. Is it during meal, after meal? I'm sorry.
No. Peak bile salt synthesis, that means brand new bile salt synthesis occurs in between meals.
Thank you.
During the meal, all you're doing is recycling your bile salts. When they come back to the liver just conjugates them again and sends them right back out. So everything I just outlined to you guys is right here in this picture. Remember we talked about it in biochemistry. I just want you to review this picture sometime and you should be able to talk it out so you see how everything is traveling around. Okay? Who drops off what where is what they like to ask. All right, developmental atherosclerosis. Remember I went through this for you? What's the first step in developmental atherosclerosis? Honestly, first thing that happens, Damage to endothelium. Second thing that happens, Karina, fat deposition. It's called a fatty streak. Remember, I told you to discover that even as early as 6 months of age. And the people who have strong family history. That's why we do statins early in life. Now you can't wait until the driver's. Okay, so endothelial damage, fatty streak, and here comes the macrophage, eats the fat, and then tunnels underneath the endothelium. What do you call a macrophage when it eats the fat? Cesar. Foam cell. When it tunnels underneath the endothelium, we call it what now, Melissa? When it tunnels, Nate, what do we call it now? Mitchell, what do we call it now? No, it's not to the foam cell. Once the tunnel's underneath, you got a bump in the road. And that bump in the road is called what, Reed? No, it's not called a plaque. Anna, it's called an atheroma. And then the plaque, the atheroma rather, causes turbulent flow, which causes more endothelial damage. When endothelial damage occurs, what clotting factor pumps out of the basement membrane? Steve? Right, VWF. And therefore you start another clot, form fibrin deposition, and when you put it together, that's called atherosclerosis. What percent stenosis would give you symptoms? Zena? What percent stenosis would give you symptoms? That's 70%. What percent stenosis would give you events? Karina? 90%. Okay. I mean, this is just same old stuff, folks, but make sure you go through that.
I have a question.
All right, I was about to call your name. Is this Ryan Ford?
Yes.
Yes, go ahead. Question.
When does the matrix metalloproteinases come through?
After you have atherosclerosis. Remember, their job is try to shave down that plaque, and then that's why they can cause the plaque to rupture. So metalloproteinases come after you have atherosclerosis.
Okay.
Yeah. So
Excuse me.
hyperlipidemia. Oh boy, Mabel, yes, Mabel.
I'm sorry, sir. Please don't be angry. You said
No, I'm
that
not.
when
Wait a minute, Mabel, I'm not angry with you. I'm just saying, put your hand up so I see. You know, Ryan had his hand up.
Okay. He said that-
I know who's putting their hand up. All right, go
okay,
ahead.
he said that when macrophage eat macrophage that is called foamy-cell, then what's
No,
happened
when
to
macrophage eats the fat, it's called
Okay,
a foam
fat.
cell. Yeah,
Okay,
then it tunnels underneath the endothelium. Now you call it an atheroma.
okay, if it's on if it's on top of epithelium, it is not called atheroma, right?
It's called an atheroma when the macrophage tunnels underneath the endothelium. That's why he pushes it up, which
Okay.
is what creates the turbulent flow.
All right, thank you.
All right. So hyperlipidemia. The problem is metabolism of the lipoprotein is defective because you're making it, but that means you're not storing it away anymore. It could be carrying triglycerides, cholesterol, or both. Remember we talked about this before. Hypertriglyceridemia, xanthelasma, recurrent pancreatitis. That means you got a problem with VLDL, IDL, or chylomicron. See, by knowing what each one carries, that way at least I know what my answer has to talk about. It's got to have one of these three in it. If they're talking about triglycerides. If it was cholesterol, that's LDL. That's the only guy you got to know. Okay? Hypercholesterolemia, you get early coronary disease or xanthomas, which are cholesterol pads on extensor tendons. And the only one who carries them, LDL. There's the 6 hyperlipidemias, and we went through this before. We're just going to quickly remind you. If you got elevated chylomicrons, it means everything is working fine until you get to chylomicron. That means lipoprotein lipase at the liver is not working because you're not able to metabolize it. How do we treat this? You don't need medication. Just eat less fat in your diet. So that's the question I like to ask. Which hyperlipidemia does not require medication? This is the one. Type 2A, elevated LDL. And type 2B, LDL and VLDL. Both of them are associated with obesity. For these two, it's downregulation of the receptors because you're eating so much in your diet. And that's why they're just floating around in the blood. They don't know where to go because receptors are all inside the cells. Type 2B is the most common in the general population. Type 3, IDL, ApoE, is a problem, Kathleen, because remember, IDL uses ApoE. So that's why if E is not working, IDL doesn't know what to do. Type 4, VLDL, that's C2 is defective. And type 5, VLDL and chylomicron, again, C2. Now, type 4 can also be because of lipoprotein lipase at the adipose. Remember, there's lipoprotein lipase everywhere in your body. So make sure you know what organ you're trying to pick. Anyway, this is how you can remember how each one is caused, and that's what they'll ask. If you want to treat cholesterol problems, statin's the first line for all cholesterol problems, LDL. What they do, block HNG curve reductase, which is a rate limiting enzyme for cholesterol in the liver. Because they're once a day, they're fat soluble. You already know all the side effects. I don't have to repeat them. All right, remember, update, you don't have to follow CPK and liver enzymes anymore every 3 months like we used to. Why? Because we know it destroys coenzyme Q. But coenzyme Q is replaceable. So that means the liver disease is reversible. So now you wait till they complain about weakness, check liver enzymes, check muscle enzymes. If the liver enzymes more than triple, or muscle enzymes more than 10 times normal, start coenzyme Q. You don't have to stop the drug. Start coenzyme Q, everything reverses. You saying, Rachel? Is that staying Ashley? All right. Which one of these statin, Ashley, is the most water soluble? Look at the list. Which statin is the most water soluble? Kathleen? Lauren? Neha? Which one? Rosuvastatin? No, let's see if somebody online remembers. Idonis, which one?
Pravastatin.
Which one?
Pravastatin.
Yeah, Provastatin. Remember I said P for P it out. Okay, always gotta remember in your brain how you file it away. P for P it out. Okay, otherwise they're all fat soluble. And let's see, what do they call them? High intensity statins. Ida, which ones? Atorvastatin and rosuvastatin. All right, cerebrastatin and valdastatin got pulled off the market because there's too much rhabdo. Okay. Cerebrastatin and valdastatin got pulled off the market because too much rhabdomyolysis. Shri, you have a question?
Yeah, so does pravastatin not cause hepatitis then?
Right. It's not that he doesn't, it has the lowest risk for it.
Okay.
Yeah. All right. If the statins are not enough, then you add the bile resin binders, cholestyramine and cholesterol. That's not enough, then you can add nitrogen or propofol to block VLDL. Because VLDL eventually breaks down to LDL. So that's why it's not first line, because it's like 3 times removed. But it does work. All right, Anders? High intensity means it's very potent. The atorvastatin and rosuvastatin, very potent. Remember, they're being used in MI. Remember, they can coat the heart right away and retard the inflammation from touching your heart. And that makes a big difference, decrease mortality. Yes.
So, everything like a big complex, like, the niacin that is just for something else.
Yep.
They're like a.
No, if you're taking B complex every day, that's the same thing as taking niacin every day. Which is okay. Yeah. And you don't have to
Wouldn't that be a problem?
taking one vitamin every day. Taking B vitamins every day?
Yeah, like a multivitamin in general.
But why? Why is it a problem?
Because it's increasing insulin resistance.
Niacin? Yeah, if you're taking niacin as a physiological level, it does not cause insulin resistance. Remember, it's